Saphenous vein incompetence happens when valves fail, letting blood pool backward. First-line treatment is thermal ablation, using a laser or radiofrequency catheter to burn the vein shut. To prevent thermal nerve injury, physicians inject a tumescent anesthesia fluid shield. These multiple needle sticks are painful. This led to the development of the non-thermal frontier, devices like VenaSeal and ClariVein. By eliminating heat entirely, they also eliminate the need for those painful tumescent injections. Because both are categorized as non-thermal, it is tempting to treat them as interchangeable options. However, applying that logic in the clinic leads to poor long-term patient outcomes. Let's look at exactly how they close the vein, starting with VenaSeal. This device delivers precise droplets of cyanoacrylate glue into the vessel. When paired with manual external pressure, it creates an immediate, permanent chemical bond between the vein walls. ClariVein operates on a completely different pathway called Mechanochemical Ablation. A motorized wire tip rotates rapidly to scrape and shred the inner vein lining, while simultaneously bathing those fresh wounds in a liquid sclerosant. ClariVein relies entirely on this combined action. Studies show that neither the mechanical trauma nor the chemical wash can successfully seal the vein on its own. These divergent mechanisms leave two very different biological footprints. VenaSeal permanently leaves a foreign body, the glue, inside the leg. ClariVein uses a liquid sclerosant that the body absorbs, relying on natural tissue fibrosis to keep the vein closed. This chart tracks the anatomical occlusion rates of both devices over time. At the 1-year mark, the results are already splitting. VenaSeal maintains near-perfect closure between 97 and 100. Looking at the data from the VCLOSE and LLAMA trials 5 years out, we see a massive divergence. VenaSeal degrades into a secure fibrotic cord, holding steady at a 91.4% success rate. ClariVein's closure drops to just 47%, meaning the treated vein reopens in more than half of the patients. Those failing vessels have real surgical consequences. Because ClariVein has such a low long-term success rate, roughly 21% of patients will eventually require a second intervention, compared to just 8% for those treated with VenaSeal or thermal heat. This creates a hidden cost paradox for clinics. The ClariVein device and its consumables appear cheaper upfront, but those initial savings are eclipsed by the financial and physical toll of performing repeat surgeries. Despite its durability, VenaSeal carries a specific complication profile. Because of the permanent glue, between 10 and 32% of patients develop a phlebitis-like abnormal reaction, or type 4 hypersensitivity. It's a localized inflammatory immune response to the foreign material. ClariVein avoids this hypersensitivity entirely, since there is no glue left behind. However, the higher risk of the vein reopening often leads to dark hyperpigmentation forming on the skin's surface directly above the failure site. The physical recovery requirements differ as well. The manufacturers of VenaSeal explicitly state that patients do not need to wear post-procedure compression stockings. For ClariVein, the use of compression garments is still variably recommended by practitioners. Furthermore, non-thermal tools face strict anatomical limits. Current clinical guidelines state that if a vein's diameter exceeds 10 millimeters, both VenaSeal and ClariVeins should be set aside in favor of traditional thermal ablation. Neither of these devices is a perfect universal tool. Their specific strengths and weaknesses dictate exactly which patients they are suited for. Let's apply these constraints to a clinical scenario. You have a patient with an 8 millimeter incompetent vein. They absolutely refuse tumescent anesthesia, they will not wear compression stockings, and they are afraid of leaving permanent glue inside their body. We can step through the elimination logic based on the data. Thermal ablation is off the table because it requires tumescent fluid. VenaSeal is out because the patient refuses a permanent foreign body. That leaves ClariVein as the only viable biological match. But this creates a necessary clinical compromise. To use ClariVein without compression stockings, the physician must explain that the patient is accepting a 47% chance of success at 5 years, and a 1 in 5 chance they will need another operation. This matrix summarizes our ultimate decision protocol. Thermal ablation remains the first-line gold standard, especially for veins over 10 millimeters. VenaSeal is your highly durable non-thermal choice, provided the patient accepts the risk of hypersensitivity. And ClariVein sits in a narrow niche, a specialized tool for when permanent adhesives and tumescent fluid are strictly ruled out.